Hi everyone. My name's Ankur Barua. I'm one of the consultants from Birmingham Midland Eye Centre in the UK. Thank you to the Romanian Congress for having me, and thank you to Raina. Let's see if I could use this. Right, so financial disclosures. Obviously, Raina have supported me in giving me this, for me to do this talk. I have other financial disclosures, but not relevant to this talk. Okay, so the first question you may be asking is, why have I been asked to speak about this? Now, I have quite a good background in terms of refractive surgery and cataract surgery. I use a wide variety of lenses, so I don't just use Raina lenses, I use many, many different lenses for my surgeries. I do clear lens extractions and refractive lens cases, and I have a channel where you could see me doing all these cases, but others as well, because I'm a corneal specialist as well by trade. So I'm going to talk to you about the EMV lens and the EMV toric lens today. And I'm going to discuss the use of spherical aberration to help with patients who want to get a bit more of a range of focus with their vision. In terms of this lens in particular, I was approached at quite an early stage to try these lenses out. So I've been using them for about 3 years now, and I'll give you my results and try and give an idea of how to use these lenses in real practice, and tips and tricks as well. In terms of evolution of lenses, we all know about the background of how cataract surgery started over 3,000 years ago, and we've moved towards having intraocular lenses, so with Harold Ridley, with Raina, and then subsequent to that, we started to develop different types of lenses to try and mimic the natural lens. Now, still at this stage of technology, we still haven't got something that would mimic the natural lens completely, but we could look and see what we have available to us. And these are the reasons for these kind of talks, to give you an idea of what lens is available. Now, in terms of my refractive practice, if, for example, I had about 100 patients in one go, about 5-6 years ago, I would have probably done about 80% trifocal or multifocal or bifocal segment, and about 20% monovision. Now, about 50 to 60% of my practice is these extended depth of field lenses. So this has really changed my refractive practice over the last couple of years. So we're kind of faced with many, many different types of lenses now. So the umbrella term of EDOF is not a true term for many of these lenses. So all of us will say to our patients, oh, we've got these new lenses which have extended field of vision, like a camera lens. But all of these lenses have different features to them. So you can't compare really one lens to another without looking at the technology. And the reason why I say this is because each lens has its own caveats, own benefits and risks, own things to look for. Now, for a true EDOF lens, you really have to change that aberration surface to be able to give you the vision or the depth of field. There's some other lenses that present themselves as EDOF lenses, but actually they're actually low multifocals, low add multifocals. So they still use the diffractive design to be able to give you a bit of reading add, but not enough to give you close vision. In terms of the RayOne EMV lens is classed as a monofocal plus, so basically giving the patient a little bit more independence or social vision, and you could work with monovision to be able to give them true potential spectacle independence. In terms of spherical aberration, now, going back to physics and use of spherical aberration, it's really important we know about the background of the optics of the eye and the optics of how we're going to use a lens to replace a cataract or a natural lens to be able to give the patient the best result. So as we all know, spherical aberration is a high-order aberration. So the most obvious ones we all think about would be sphere and astigmatism, so cylinder. And then you get the next step down, which is looking at comma and spherical aberration. So the simplest way of looking at spherical aberration is looking at the rays from the center to the periphery. When you get positive spherical aberration, the rays in the periphery bend closer to the front of the eye, creating a myopic shift, compared to negative aberration, spherical aberration, where the focus goes further back. So the highlight of this is that the RayOne EMV is one of the few lenses, or one of the only lenses, that works on the positive spherical aberration. So you add positive spherical aberration to the eye. And we all know that the natural spherical aberration of the eye is positive, so it's plus 0.27, plus minus 0.1. Now, the question I often get from colleagues is, how can you just mess about with a spherical aberration? And that's true, you can't just mess about with spherical aberration. If you add too much to the eye, so if the eye's already got a high spherical aberration, for example, somebody who's had previous myopic LASIK, you could potentially push the eye into too much spherical aberration because you degrade the quality of the image. So yes, you may get a depth of field, but the quality of the image will be degraded, and you get reduced contrast sensitivity. So this is why you can't just put lenses in and just say, okay, this is going to give you a universal result, as with anyone. So like with any other lenses on the market, you really need to think about how you're going to implant it and what lens is best for the patient. So Professor Barrett was the one who developed this lens and worked on the theory of positive spherical aberration. And it behaves like an enhanced monofocal. So I've had some patients who've had this lens and they've suddenly come in saying they could read really close. And I've had some patients where they're saying they could read the computer just fine and they got good social vision. The issue here is that each patient has a different result because of the natural optics of the eye. But generally, this is quite a safe lens to use because even if the patient doesn't get the full quality of vision that, in terms of the depth of field, they will still be getting a good single vision for distance if you target for emmetropia. The main thing here with these lenses, as with any lenses, is first you want to target the refractive aim, and then you work on the aberrations and see if the aberrations will work. For example, somebody who's had a myopic LASIK, they may not have a good result with a lens such as this, simply because they've already got high positive spherical aberration. In terms of the way it works, so again, I've mentioned this already, there's an addition of spherical aberration with the aberrometry of the surface of the lens, and you're kind of working with the cornea to be able to add a bit of spherical aberration and give the patient a little bit of a myopic defocus. And these are MTF curves, so we're looking at the contrast, we're looking at the way the image comes through, and this is with a standard monofocal lens. And then you move on to the RayOne EMV. So when you add a bit of positive spherical aberration, they get a myopic shift, but a hyperopic tail as well. And this compares to other lenses in the market with potentially negative spherical aberration, where you get quite a uniform upward bell in the middle. So with the RayOne EMV, you get this hyperopic tail, which is a bit prolonged, but you also get a myopic tail as well. So in my hands, this has worked very well, and I'm happy to speak to any of you about this lens and other lenses that I've been using. But in my field, I try and look at the lens, look at the patient, and try and merge them together, so I don't use one lens for everybody. So again, you could use this for mini monovision or monovision. So in fact, when you look at my figures, I've only done one patient with true monovision with this lens. Most of them who've asked for monovision or wanted a bit more spectacle independence, they've been offsetting them by about minus 0.75, minus 1, nothing more than that, and they've been just fine. With the EMV, you get a slightly larger area or zone where they merge together, so the two tails merge a bit better. So in terms of ways to use the EMV lens, you could go for bilateral emmetropia, which is just fine for the majority of patients. Now, how I present it is a social vision lens. So I say you could do most things day to day, but you probably need glasses for reading, for close vision. But things like social vision, like reading a menu in a restaurant or kind of doing day-to-day things, should be fine. Now, just be careful that some of these lenses and some patients are very sensitive with the light level. So if the light levels are low, you might get a change in the quality of the vision. And this is especially apparent with these depth of field lenses. Now, in terms of trifocal lenses, I use a wide range of different trifocal lenses, but I'm starting to see patients moving further away from that and going towards this as an option. Okay? So these are options you have in terms of options for one versus the other. The other question I get a lot is, which eye should you do first? So, for example, you might get a patient with a cataract that's affecting more the non-dominant eye and less cataract in the dominant eye. I would still work with the dominant eye first, because you want to get the dominant eye on target and then see what you do with the non-dominant eye if you want this to truly work. So this is the range of the lenses that Rayner do, the RayOne platform. The unique thing about the RayOne platform is it's very stable throughout the whole of the range. I even use the hydrophobic lens a lot. So for my combined corneal surgeries, I use the RayOne hydrophobic a lot. The thing to remember with this EMV lens is it's hydrophilic, so I don't use it in any patients with corneal pathology, such as endothelial changes, or any patients who might need corneal grafts in the future. In terms of the platform, they're all universally the same, and I'll show you a video of that as well. And this is what we've been talking about just now. So you can see the lenses look pretty much the same, and the loading mechanism, everything is pretty much the same. So it's very easy. Once you get the hang of it, it's very easy to use. So in terms of the feedback I've had from patients, I've got experience of both the RayOne EMV and the EMV Toric since it was launched, and the results are generally very, very good. And it's easy for me to say the results are good, but I'll show you the evidence of this a bit later on. Now, it's not a diffractive lens, so you don't need to worry too much about glare and halos, but the symptoms that some people may get is in the evenings when they're adapting to the lens, they may get a little bit of what they will describe as glare, but it's just the degradation of the image compared to when it is when the pupil is a bit smaller. As you know, the spherical aberration increases as the pupil increases in size, so that might affect the quality of the image that they get. This is an example of a video, so it's very similar to a video I just saw when I came in. So this is quite a dense cataract. So as you see, I went through a small incision. I use Vision Blue because it's a white cataract. Always when I do these kind of cases, I make sure I decompress the eye. So when I'm doing the first lift, I decompress the eye with the hydrodissection cannula. And here I always use HPMC. So one thing to note, when you're doing any refractive lens, whether it be monofocal, multifocal, or EDOF lenses, I always protect the corneal surface and make sure you treat the dry eye beforehand, because it can affect the biometry readings as well. So here I'm taking all the fragments out, and the point here is you really need to do a good polish. And this was me yesterday, because I hadn't had a video of me loading it. So it's very easy. You just rip the foil off, you pour the water out, and you just inject the viscoelastic in through the little peephole and just close it. So this is in my private office, private theatre there. I'm just injecting the lens very gently. It comes out very uniformly. The hydrophobic lens acts a little bit differently, but it's still, once you get used to it, it's fine. And it's pretty easy to load. And like we saw before, you want to make sure you take the viscoelastic out from behind the lens. So I use a silicone tip or a soft tip IA, and I've had patients where they've come to me where they've had a myopic shift because of viscoelastic trapped behind the lens. So just make sure you do the viscoelastic removal effectively. So, in terms of chair time, I've mentioned this briefly already, but when you're choosing the EMV lens, it's really important to make sure the patient understands their expectations. You're not going to give them spectacle independence to the point where they might get it with a trifocal lens. Even if you use monovision or mini monovision, they may, on occasion, may still need low-ad reading glasses. So it's just important to get through to them about the expectations. When you do your first few cases, choose your patients very carefully. Try not to go for the complex ones first, for example, the video that I just showed. And you need to make sure your biometry is as accurate as possible. So I'm OCD, so I get 2 or 3 biometries succession. If you choose an EMV over a trifocal, it may be because the patient's not suitable for a trifocal. And yes, you can use the EMV or an EDOF lens, but you need to treat the pathology that's affecting them. For example, if they've got dry eye, ocular surface disease, blepharitis. In terms of the vision chart, again, there's good simulations that patients could see about what they could expect. But often, if you deal with the expectations beforehand, when they come back to clinic, they'll remember all of that and they say, okay, this is what I've ended up with and this is fine. Now, I'm going to give you a couple of case studies. Let's see how much time I've got. Okay, got enough time. So, this is an example of a patient who is a 48-year-old. He is a pilot for a famous airline company. I'm not going to mention any names. Not the one last night that came in at 4 o'clock. The second thing is that he plays in a band, so he's a singer-musician, and he's got just a unilateral cataract. And he came in with the premise that he was going to get a trifocal lens. And he didn't realize that as a pilot, it probably wasn't suitable, especially as an international pilot, not just a domestic pilot. He also had mild myopia. So in his non-dominant eye, he was around -1, which made my life a bit easier, and he had no cataract. He was unsure about the options, and his main concern was about how this would affect his work. So he has got no diabetes, no glaucoma, no other history. So in essence, I didn't want to compromise his pilot's license, and I wanted to make sure his non-dominant eye was truly myopic, and not just myopic because of early cataract, which it wasn't. His prescription was stable for a long time. So the questions I had to ask, why has this young chap got cataracts early? Was there any history of trauma? And then I had to think about what lens to choose. And ultimately, we decided on EMV. I didn't choose EMV because that's the only lens I ever used. It's because I chose it as I felt it was the best one. We checked his spherical aberration with Aladdin biometry, and we found that the pentacam was regular and there was minimal astigmatism. So he was ideal, and we wanted to maintain his distance vision regardless. He wasn't expecting to be able to read really close up, but he wanted to be able to read music when he was playing his guitar. and drums. He plays like two. And the safety, he was worried about the glaring halos. So eventually, when he came back, I only saw him like a year after surgery, after he'd had a few follow-ups. And this, when I prepared this slide, he just had come in and his vision was 6.6. And in his non-operated eyes, 6.12, so he's using mini monovision. And with both eyes open, he's 6.6 and 5. So he's extremely happy. And this is a random fact, but I went on a flight to Tenerife recently, and he was a pilot, and he was speaking on the announcement, so it's completely random. But he's very happy, and he feels his vision is the best it's ever been, which is a very satisfying thing for a patient to tell you. Now, we have to prepare for the next eye. So if he develops a cataract in the left eye, I've got options here. I could leave him with mini monovision. I could talk about the other options. So it's not like I have to put a trifocal in because he's had trifocal in the first eye. And I wouldn't have used a trifocal here anyway. If he wasn't a pilot, then we could have considered it. Now, the second case is a 51-year-old nurse. She's a specialist nurse. She's a low myope, again around -1.5, -1, and she wears contact lens in one eye, so she's used to monovision. Now, again, she wants to be able to read the drugs, so when she's opening vials, she wants to be able to read the drugs. So an EMV lens probably wouldn't have been ideal on its own if we're aiming for emetropia, because she would have had to read the vials, and she's got cataract in both eyes, and she wanted to be able to be free from glasses for that reason. She didn't mind about being able to read N5, but a lot of the vials that you see in drugs, the print's quite small. So we discussed this again, and we made sure that the soft contact lens was off for a week at least, and we made sure that measurements were accurate. And she had a bit of underlying dry eye, so we measured that as well, and we did all those measurements. And she wasn't keen on multifocals because of the risks, and we discussed the option of EMV, and we did mini monovision, kept a -1 in the non-dominant eye, and she was extremely happy. Now, when I did the dominant eye first, the interesting thing here is she got 604.5 unaided, with N10 in that eye, not with both eyes open. So for some reason, she got a very, very good result from the EMV lens in terms of reading vision, more than we expect. Okay? So in terms of these slides, I'm going to distribute these slides if anyone wants to see them. I'm not going to spend too much time on them because we're running out of time now. But there's a lot of published studies or examples, for example, in ESCRIS and in other meetings, and the EMV has really taken off as a lens, and both for refractive consultants and for non-refractive. So it's a lens that appeals to a lot of people because of its safety profile. In terms of other colleagues who've looked at this and compared them to the other lenses, each lens has its own unique kind of benefit. But the benefit of the EMV lens mainly is that it's easy to use, it's on a familiar platform, and it gives a reliable result. The only ones that I've had questionable results with are the post-LASIK patients. So those patients take a while to settle down, and not all of them will be 100% happy straight away. So you have to be very careful about patients who've had previous laser refractive surgery, because you have to really look carefully at the spherical aberration. In terms of target, again, looking at the biometry carefully, choosing the first minus. So, for example, here, I wouldn't choose the first plus, I'd choose the first minus if I was aiming for emetropia. Try and avoid going for a hyperopic result. And I usually do the dominant eye first, as I mentioned already. Now, it varies. Different consultants do different things, but if I'm going to aim for a little bit of mini monovision, I aim for about -0.75. And some of these patients, you can't really trial them because they've already got cataract in the eyes. You can't trial monovision on them. Okay, so looking at patients I've done, so this was around a year ago, so I've doubled this number now. So I've done about 200 cases altogether, including EMV toric. And if you see, I've only done one full monovision patient, including the time up till now. The vast majority end up going for emetropia. There may be insured patients who just want to top up a lens. They may not fancy the idea of mini monovision when you explain to them. But generally, the results speak for themselves. I've had no complications from the lenses, no posterior capsular tears or anything like that. I've had no patients who've had to have the lens explanted. Expectations is the main thing. So patients may tell you, yes, I could do what you told me, but maybe I would like a little bit better. So they might want that reading vision that they never thought they needed. Thank you for listening today. If you have any questions, please, I'll be around for the rest of the day, but please feel free